through the conference. So the topics I chose for this year are very practical, and many of us have these practices in our NICUs, and I'm just going to be giving you a few slides about each of the practices that we do usually in our daily care for neonates, and we examine the evidence of these practices. So the first topic I'm going to talk about is antacid use in NICU. I know Professor Manzoni published extensively about the use of antacids in the NICU. Unfortunately, there's a lot of use been observed in the neonatal practice. So we will examine if they're really helpful or harmful. The other topic we really rarely touch base on is the postpartum depression. It's going to be a full lecture about postpartum depression by Dr. Lemia, and we are hopefully shedding some light about this very common illness that we don't deal with as much as we should. The other topic in which we practice regularly now in delivery room is delayed cord clamping. I'm going to give you a flavor of the international guidelines and what's coming through the NRP 2020 in this regard, and maybe we will have some discussion about that. Also, common practice is that we worry about blood transfusion in terms of association with necrotizing enterocolitis. So is there a true causation with the factor that cell breast transfusion, or just we don't have a clear clarity about this issue? Also, analgesia is a well used pharmacological agent used in an NICU. I'm going to just examine the role of morphine in premature infants. Is it helpful or harmful? Again, a lot of babies will be evaluated for sepsis, and we use C-reactive protein in initial evaluation. So I'm going to talk about if it's really useful to use TRP in the late onset sepsis. So starting with antacids used in NICU, is it helpful or harmful? There is a really strict indication to use antacids in the neonatal age, which is erosive esophagitis or GI ulcers. Other than that, there's really no established use for it, and there's a lot of studies that examine this role of antacids. Pretty much all the studies agree that there is really no change in the gastroesophageal reflux symptoms in patients who receive antacids, because the babies don't have an acid reflux. They have a reflux, but there's not really acid reflux. And there's really no effect on apnea, bradycardia, or desaturation when we use antacids. Also, there's no evidence that gastroesophageal reflux and the use of antacids within that context alter the incidence of bronchopulmonary dysplasia later on. So we know that there is really a very limited role in using antacids, but what's the harmful effect of antacids? There's a lot of studies also that shows there's association between infections and the use of antacids. Especially we worry about necrotizing enterocolitis because we elevate the pH of the stomach, which is the first defense mechanism against germs that the baby swallows. So we know that, and this is really a lot of publications by Dr. Manzoni about the association with sepsis and the use of antacids. Bone fracture, because we alter the acid-base balance by giving the H2 blocker or proton pump inhibitors. And there's an increased risk of allergy in childhood. So what do we do to really reduce the use of antacids in the NICU? This is a quality work that's done at Brigham and Women Children in Boston, and they evaluate an area between September 2018 and 2019, and they look at this from the multidisciplinary team approach. So we know that the indications for using antacid is very small, and it's only about 20% of the total use of the prescribed medication. So what do we do to decrease the unsubscribed or not authorized use for antacid? Is we form a multidisciplinary team. We write guidelines and we inform all the team about the guidelines, and then we implement the guidelines and we do staff education. When we do this, actually, when it's done, this project in Brigham Women Children in Boston, they actually reduce the unindicated use for antacid to almost zero. In the same time, they increase actually the prescribed indication for antacids to 100%. So moving to postpartum depression, and it's really, this is an unknown or unnoticed disease that we really should pay attention to. We know that the babies, when they're born and they admitted to an ICU, both parents go under tremendous amount of stress, and they have, if we compare the maternal postpartum depression between the babies who are admitted to an ICU and the babies who are not admitted to an ICU, we see that in general population, the percentage is about 19%. And this is also a poster that was presented in Hot Topics 2019 in the US. When we talk about the NICU population, then that percentage of postpartum depression goes almost 4 times higher. Also, there is a higher suicide risk if we compare in postpartum period from 14% to almost 33%. So AAP recommend that all mothers being screened for postpartum depression at intervals after the birth, 2 weeks, 1 month, 2 months, and 4 months. And that's during well-child visit. Also, postpartum depression only not affecting the mother, it's affecting the baby. So we have a negative impact on both of cognitive and motor development of babies, and this is well established in the studies. And also increased exposure to stress in ICU for the babies affects overall brain development of the functional ability to the baby. In addition to that, the baby bonding to the mother is decreased when the mother has postpartum depression, which leads to less response to the feeding cues that affect the breastfeeding. Okay, moving now to a very common practice, which is delayed cord clamping. That's really now routinely practiced in almost all our units. Now, I'm going to compare that to the cord milking, which is really not a lot of solid information about cord milking at this point. So delayed cord clamping is recommended by American Academy of Pediatrics for 30 to 60 seconds for term and preterm infants who are not requiring immediate resuscitation at birth. Although it's a weak recommendation, but the impact is very high, so it's recommended by AAP and in the NRP 7th edition. It's not only the NRP that recommended this, but it's a lot of international bodies recommend the use of delayed cord clamping, or what we call physiological cord clamping. And the periods vary between 30 seconds to 60 seconds, but for most part, up to 1 minute. So what's the benefits of delayed cord clamping? We know that to maintain cardiac output, to maintain oxygenation, maintain body temperature, protect against rebound hypertension, post-asphyxia. And now there's some studies about delayed cord clamping in the context of HIE and the benefits of the delayed cord clamping. And that's in the works, like to find a way that to do delayed cord clamping in the same time start resuscitation. Also reduce the risk of pulmonary hypertension, congenital diaphragmatic hernia in newborn, and improve the motor development in babies. This is really a not new concept. Aristotle, 350 BC, described what we know today as cord milking, where he described that nurses were already skilled in squeezing the blood back out of the cord into the child's body. And once the baby is previously seen as drained of blood, comes to life again. So Aristotle really described the cord milking as we know today. So cord milking has some benefits, but it has some also complications, mainly due to the lack of cerebral autoregulation in premature babies, especially where you sudden increase or pulsation of blood into the brain can cause increased venous return, caused by increased venous return to the right side into the PFO, into the aorta, and maybe it can precipitate IVH. So this is a poster that's also shown in Hot Topics in 2019, which compared the carotid artery blood pressure and carotid artery flow in the babies who received cord milking. And as you notice on the left side of the side of the slide, you see that the carotid artery blood pressure goes in pulsation according to the time that we do the cord milking. Whereas in a delicate cord clamping, there's a smooth and sustained increase in the carotid artery blood flow, not in the pulsatile form, which can actually be harmful to the premature brain. So from that point, the NRP 7th edition recommendation is to suggest against the routine use of cord milking for infants born less than 28 weeks. And trials are underway, and we should fill this gap by 2020, where we are now due for the NRP 8 to come out. So how does this compare to the NLS? We know the NLS is the UK recommendation for the neonatal resuscitation. NLS say that umbilical cord milking may prove alternative to delayed cord clamping in a baby who needs resuscitation. So they kind of hinting to the benefit effects of cord milking, but there's no enough evidence to recommend this as a routine measures. And if you look at study is that done in that regard, this is a Primo 2 trial, which conducted in June 2017. It was supposed to be completed by December 2024, and recruited a lot of babies, 1,717, but then majority were excluded. Eventually, 540 babies were recruited, and they randomized them to either delayed cord clamping or cord milking. And this is non-inferiority. The hypothesis is that cord milking is not inferior to the delayed cord clamping. This study had to be stopped actually by the board that approved it because of this finding. They found that severe IVH is actually significantly higher in the cord milking compared to the cord clamping, especially in the small babies, 23 to 27 weeks gestation, where it is about 4 times that much of IVH happening in those smaller babies. So suggested that routine cord milking should not be done less than 29 weeks gestation. Moving to the back RBCs and neck association, we know from this older study in 2012, meta-analysis was done and showed increase in the transfusion-associated neck in those when they compare these 4 studies. Just an update on a newer studies which was published in 2018 in Journal of Prenatal Medicine, and included a lot more studies that happened since that time, which showed really no difference between the incidence of neck among the babies who transfuse or not transfuse. So our understanding of the association between transfusion and NEC maybe is related to the anemia that's associated with NEC, and because of the effects on the tight junction disruption, which increase the passage of the pathogens from the mucosal surface into the lumina, and then it affects the babies, causing infection. So maybe the association is because of the anemia, not because of blood transfusion. So in conclusion of that recent meta-analysis, there's really no association between the RBCs, transfusion, and NEC. Maybe severity of anemia that caused the NEC, and interaction maybe because of the components of the red cells, not the transfusion itself. Moving along to procedural pain, we use a lot of analgesia for our painful procedures in NICU, and sometimes we use morphine as a way to reduce the pain. And we know that babies' response to pain when they're premature is different than when you're full term. So full term will give you facial expression, heart rate changes, or oxygen saturation changes. And if premature babies, because of prematurity of their brains, really there's not a lot of signs to give you indication of pain. So this study was published in Lancet in 2018, compared the morphine to placebo in the reactivity to pain stimuli. So they look at the brain activity, they look at the reflex activity, and they found really there's no difference in the brain EEG or EMG for the babies who receive placebo and versus morphine. So we know there's really no difference in reaction to pain if you give morphine or if you give placebo. But what about the harmful effects of morphine? We know that all babies, especially premature babies, when they have morphine, they have some side effects from morphine. So in terms of apnea, there's a respiratory support need. So this is a very known fact that the baby has this. Sorry, I got this. So the conclusion of this study is that administration of oral morphine for non-ventilated babies, they have no evidence of efficacy, but they have a harmful effect. So we should really not use oral morphine for analgesia for painful procedures. Last topic I want to touch base on is very practical for our NICUs, where we use C-reactive protein as to guide our decision to initial evaluation for sepsis in the late onset sepsis in a preterm infant. So this is a published only in February 2020, which is looked at the C-reactive protein, and they found actually there's very low sensitivity of the C-reactive protein is 0.62. Sensitivity. That's 40% is really not sensitive, and 60% only sensitivity. Finding that the CRP should not be used as a determining factor for late onset sepsis if we want to start antibiotics or not starting antibiotics. So we should not be depending on it, even though we can look into the usefulness of C-reactive protein to guide our evaluation of baby subsequent days in terms of how effective is our antibiotics treatment. So in summary, answering the questions that we raised in the beginning, antacids in NICU, are they helpful or harmful? The answer is no benefit in most of the indications that they are used for with really proven harmful effects. So we really should limit the use of antacids in our NICU. Postpartum depression, are we paying attention? Do we need more focus about recognition and management? Maybe we should give a questionnaire to the mothers when they come visit us in 2 weeks, 1 month or more if the baby stay with us, to try to refer the mothers to appropriate services for treatment of postpartum depression. Delayed cord clamping versus cord milking. Delayed cord clamping is beneficial. Cord milking can be harmful. So stay tuned for end 2020 NRP and then position. Hopefully it will come soon. And in anemia transfusion, is it confusion or causation? Fact RBC transfusion alone does not really cause an NEC. Oral morphine for non-ventilated babies does not prove to provide anesthesia and will have harmful effects. And a CRP initial evaluation for large onset sepsis does not help in aiding decision in who to treat. I hope that will give you a flavor of the coming days, and I'll be happy to answer questions if anybody have any questions.